Hello friends, welcome to the session of OBS Gynae FMGE CBoT 3. I am Dr. Harmeet Goel discussing the OBS Gynae questions. Hope you must have done the questions well. Now question number 1 is a 32-year-old woman shows up with a positive urine pregnancy test, 18 weeks of amenorrhea, and she has a history of ejecting the results of conception and is complaining of bleeding per vaginum. Fundal height as determined by abdominal examination corresponds to 14 weeks of pregnancy and open internal os is seen during the vaginal examination. Which of the following describes it as most likely? So whatever may be the language of the question doesn't matter, but you have to get the clues. Okay. So number 1, she is pregnant because urine pregnancy test is positive and the period of gestation according to the dates. Period of gestation is 18 weeks because it's written in the question 18 weeks amenorrhea, and there is history of bleeding per vaginum, bleeding present, and per abdomen the fundal height is corresponding to 14 weeks. Okay, that means on examination the fundal height is somewhat here. It should be at this level. Okay, so fundal height less than the period of gestation. Number 1, it is wrong dates. Number 2, it can be oligohydramnios or it can be IUGR, but IUGR usually develops in the 3rd trimester. Okay, so whatever may be the possibility, but one thing is, in the finding you have to read the question carefully. In the findings, the cervical os is open and bleeding is present. Period of gestation is not corresponding with the fundal height. Okay, so period of gestation and the fundal height are not matching. Fundal height is less than the period of gestation. So what type of abortion it will be? Is it a missed abortion, complete abortion, inevitable abortion, or is it incomplete abortion? So how to differentiate between them? So it will be incomplete abortion. Why I am saying so? Because the cervical os is open and the fundal height is less than the period of gestation. That means some of the products must have expelled by the time you have done the examination of the patient. Maybe the period of gestation is given to us is 18 weeks, okay, but the fundal height is not matching with it and the cervical os is open, so it is more likely to be an incomplete abortion. Let us see in this diagram. In this diagram, what I am trying to explain is, suppose if the cervix is closed, no products are being felt and bleeding is present, but the fundal height is equal to period of gestation. In this case, it will be considered as threatened abortion and you have to get an ultrasound done to check for the cardiac activity. If cardiac activity is present, you can save this pregnancy by giving progesterone support. Okay. Number 2, if the cervix is open, products of conception felt but not expelled, bleeding per vaginum is present, and size of the uterus is equal to period of gestation. In that case, it will be inevitable abortion, but this pregnancy cannot be saved. So the management will be D and E, dilatation and evacuation. Now let us see the third case. In the third case, the cervix is open, period of gestation, the fundal height is less than the period of gestation. In this case, cervix is open, bleeding is present, and products of conception hanging out in vagina. Fundal height is less than period of gestation. This will be incomplete abortion. So in our question, it will be incomplete abortion, and the management for incomplete abortion and inevitable abortion is dilatation and evacuation using the ovum forceps followed by a curettage. In case of complete abortion, the cervix is closed, bleeding may be stopped or it may be scanty, and fundal height is less than the period of gestation because all the products have expelled. So we have to go for a conservative management. This is complete abortion and we have to go for a conservative management. Maybe if we feel there are some products or the fetal membranes left inside, then we can get an ultrasound done, and if there are any retained products, we can do DNC. If there are no retained products, we can just send the patient home. So this is threatened abortion where we can save the pregnancy, inevitable where we cannot save, incomplete where we have to do termination in the form of dilatation and evacuation, and complete where conservative management, nothing to be done. Now next is calculate expected date of delivery in a female with last menstrual period 27th of December 2020. Now is it 3rd of October, 3rd of September, 4th of October or 4th of September? So if we are given the last menstrual period of the female, that is 27 December, then we have to add 7 days plus 9 months to the last menstrual period, or we have to add 7 days and subtract 3 months from LMP. This formula is called as Neagley's formula to calculate the expected date of delivery. So expected date, if you add 7 in 27, it will be 4th. Now if you add 9 months, December, January, February, March, April, May, June, July, August, September, October, because it will be 4th of October 2021. Now how many percentage of pregnant ladies deliver on the expected date of delivery you gave? So remember, only 4% of the pregnant ladies deliver on the expected date of delivery that we give. Next, best fetal parameter to find out the period of gestation by ultrasound is crown rump length. In the first trimester also it is crown rump length. In the second trimester it is biparietal diameter. In the third trimester is femur length, abdominal circumference, different parameters. But most accurate will be the earliest ultrasound and we measure the crown rump length. Now one more thing you remember, if we want to describe macrosomia or IUGR, which fetal parameter is considered the best? Okay, what is your answer? What do you think? It is abdominal circumference, single most answer. The best answer will be it is the abdominal circumference for that particular period of gestation. Now Neagley's formula is to calculate expected date of delivery from first day of last menstrual period. Hadlock formula is to calculate the expected weight of the fetus on ultrasound. Johnson's formula is to find out expected weight of the fetus clinically. And Granham's classification is, this is by clinical method and Hadlock formula is by ultrasound, and Granham's classification is for placental grading on ultrasound. So remember Neagley's formula, Hadlock formula, Johnson's formula and Granham's classification. Next, a pregnant patient with heart problems is on warfarin. At what point will you switch over to heparin as advised? Which point of time you will switch over to heparin? Okay. So what is your answer? At the onset of labor, at 34 weeks, at 36 weeks or at 40 weeks. So remember students, less than 12 weeks, that means as soon as the pregnancy is being diagnosed or before conception, if she is planning the pregnancy, we should switch over to heparin. That is subcutaneous injection. Okay, 5,000 units of subcutaneous injection, low molecular weight heparin. 12 to 36 weeks you can give warfarin. Why warfarin is contraindicated in first trimester? Because it is causing teratogenic effects. Now from 36 weeks to delivery, again heparin. Okay. Now, heparin should be stopped, okay, within 6 hours of normal vaginal delivery and within 24 hours of cesarean section. After the, cesarean section or the delivery, the heparin or the warfarin can be resumed. Breastfeeding is not a contraindication. Now, why? Important question is why we are giving in the last month of pregnancy the heparin, because it is seen that if the warfarin is being continued in the last month of pregnancy, the bleeding tendencies in the neonatal brain has been seen to increase. That is why in the last month of pregnancy we have to switch over to heparin. So this is again important. So heparin should be stopped shortly or 6 hours before birth and 24 hours before the cesarean section. Breastfeeding is not contraindicated if the patient is on heparin or warfarin. Now, the manure shown in the image, you can see in this manure, there is a pregnant lady, she has been delivering, and you see the head is delivered, okay, and the shoulders are stuck up. So, this is a case of shoulder dystocia. That means this was not a booked case. The lady must have come in the active stage of labor, because had it been a macrosomia previously diagnosed or a good sized baby, we will do a planned cesarean section in view of CPD, in view of macrosomia, etc. So such situation occurs when a normal vaginal delivery occurs in an registered or unbooked patient. Okay, so the head of the baby is delivered and the shoulders are stuck up, and you see the nurse is applying a suprapubic pressure. Okay, and the legs of the lady are being flexed and abducted. So this maneuver is called as the Mac-Roberts maneuver. The Rubin's maneuver and the Wood's corkscrew are also done in cases of shoulder dystocia. It is possible to utilize the suprapubic pressure. Yes, this is true. But which pressure is contraindicated is fundal pressure. You must have seen in the labor room, the ward ladies or nurses sometimes apply the fundal pressure to facilitate the delivery of a baby. You can do it in any other case when it is, uneventful pregnancy. That means there was no complications during pregnancy, but never in case of shoulder dystocia, because the neck of the baby has got stuck up, the shoulders are stuck up. So it will cause immediate death if you do a fundal pressure in this case. Now, most likely, which nerve can be damaged in Mac-Roberts maneuver? The answer is lateral cutaneous nerve of thigh. Both these are important AIMS PG questions as well. Okay, so which maneuver or which pressure is not being applied in Mac-Roberts maneuver? Answer is fundal pressure is contraindicated, but you can apply suprapubic pressure. And which is nerve most likely to be injured if Mac-Roberts maneuver is being done? So answer is lateral cutaneous nerve of thigh. Next, what is the complication of this kind of placenta if found in the lower segment of the uterus? You can see the umbilical cord is getting attached. The umbilical cord is getting attached to the fetal membranes. So what happens when the fetal head or the presenting part descends down, okay, or there is compression, or during the process of delivery? What will happen? There will be laceration of these membranes as the blood vessels are not, as the umbilical cord blood vessels are not covered with Wharton's jelly. So what is this condition where it can lead to antepartum hemorrhage? The condition is called as vasa previa. The condition is called as vasa previa, and the type of placenta shown in this image is filamentous insertion of placenta. Filamentous insertion of placenta, and the complication it likely to cause is vasa previa, which is a type of antepartum hemorrhage, and the problem is it is a fetal blood. So in these situations, if the baby is born, in such cases mortality is very high because baby will be born very, very pale and baby may die of hypoxia. So these vessels are exposed as they are not covered with Wharton's jelly, and this is filamentous insertion of the cord, umbilical cord. The condition is called as vasa previa. Next question. I hope you have marked all these answers very correctly, because if your basics are very, very clear, you are applying your clinical knowledge, you are able to get the correct answers in OBS and Gynae. As I have already said, 30 to 35 questions out of 300 is your OBS Gynae paper, and it is highly, highly scoring among all other major clinical subjects. Now, 30-year-old women with primary infertility is being assessed to determine whether or not she ovulates. A transvaginal scan on day 9th and 11th reveals no growing follicle. Which of the following endogenous hormones action seems to be inadequate in this situation? We always know that the ovarian cycle starts with follicular stimulating hormone, which has been released by anterior pituitary, and there is a pulsatile secretion of FSH that is required. So follicular stimulating hormone acts on the ovaries and leads to the maturation of Graafian follicles. So many follicles mature. One follicle reaches a maximum size that is called as dominant follicle, and dominant follicle is the one which is engulfing the ovum. Size of the dominant follicle is 18 to 20 mm on transvaginal scan, and this dominant follicle usually secretes estrogen. Estrogen causes a negative feedback inhibition for suppression of FSH because further growth of the follicles is not required in this cycle, but it causes stimulation of LH surge. So LH acts on this dominant follicle, bring out its rupture. So ovulation, formation of corpus luteum occurs, and corpus luteum secretes progesterone, which causes secretory changes in the endometrium. So which is the hormone that is responsible for initiating the ovarian cycle, for development of the Graafian follicles, for the differentiation and formation of dominant follicle? The correct answer is FSH, follicular stimulating hormone. FSH and LH are called as gonadotropins, which are released by the anterior pituitary. Next question. A 16-year-old girl with normal breast development and pubic hair was brought to OPD by her mother complaining of primary amenorrhea. Okay. So this is a 16-year-old girl and she has presented with primary amenorrhea. The vagina and uterus and cervix were not visible, okay, during the ultrasound examination, and ovaries were present. So in this case, the uterus is not visible on ultrasound and ovaries were present, and there is a case of primary amenorrhea. So what is the finding? We have got it from the question where history and examination is written. In the history and examination, one very important feature in the beginning is breast development is normal and pubic hair are normal. That means the ovarian function is normal. So ovarian function is normal and ovaries are visualized. That means the karyotype is 46XX. So you can differentiate by the karyotype, by the clinical finding, and by the ultrasound examination. So let us see what are the options given to us. Is it gonadal dysgenesis, androgen insensitivity syndrome, Mayer-Rokitansky-Kuster-Hauser syndrome, or Turner syndrome? Let us just write down the karyotype and the gonads. In the gonadal dysgenesis, that means it is dysgenetic gonads. So it will be dysgenetic ovaries. Although the karyotype will be 46XX, so dysgenetic ovaries will not secrete hormone, so the breast development will not be seen. So this is not gonadal dysgenesis. Androgen insensitivity syndrome. In androgen insensitivity syndrome, the pubic hair will be absent. But in this question, it is written pubic hair present. And also in androgen insensitivity, the karyotype is 46XY and the gonad is undescended testis on ultrasound, which is again not this case. Now, Turner syndrome. Again in Turner syndrome, uterus will be present because it will be hypoplastic. It will be hypoplastic and ovaries will be streak ovaries. So, streak ovaries, breast development will be absent. Breast development will be absent. So, it is not Turner syndrome. So, it is Mayer-Rokitansky-Kuster-Hauser syndrome, which is, like going with this finding. Uterus is absent because it is a type of Mullerian agenesis. Type of Mullerian agenesis where uterus, cervix are absent and ovaries are present, breast development is normal, and it is a case of primary amenorrhea. So let us see dysgenetic gonads. Gonadal dysgenesis, I have already explained, dysgenetic gonads which are not functioning. So breast development will be absent in that case and uterus will be hypoplastic. So this is not with this case. Androgen insensitivity syndrome, uterus, fallopian tube, ovary will be absent. But ovaries written in this question is present. Breast development will be normal and the gonads will be undescended testis. Karyotype will be 46XY. MRKH syndrome, it will be uterus absent and ovaries present. Breast development will be normal and pubic hair and axillary hair is normal. So karyotype will be 46XX, which is given in this question. Turner syndrome, uterus will be present but it will be hypoplastic and there is streak ovaries. Breast development will be absent and karyotype will be 45XO. So that is Turner syndrome. So our answer is MRKH syndrome where ovaries are functioning. Next, regarding postpartum hemorrhage, all of the following statements are true with the exception of, means which is a false statement. So this is a question of postpartum hemorrhage, which is very, very commonly asked question. Now, what is not true in this question? Uterus is not palpable in atonic PPH. Yes, because uterus becomes flabby and uterus is relaxed. So this is true. Secondary PPH is after 24 hours within 12 weeks of delivery. Yes, that is also true statement. Medical management with uterine massage is tried for 30 minutes. This is also true. Devascularization of the blood vessels is done if the patient is hemodynamically stable. If the patient is hemodynamically stable, why do we have to ligate the uterine arteries or ovarian artery ligation? So this is a wrong answer. Devascularization is not being tried in a stable patient. If the patient, in spite of the medical management and after trying the uterine tamponade, still the bleeding is continuing and no success rate and the patient's condition is unstable, then we go for systemic devascularization by ligating the uterine arteries and ovarian arteries. So this is a wrong statement. Next question, 75-year-old women presented to our outpatient department with large bilateral adnexal masses. So there is a history of large bilateral adnexal masses and the mammography findings are typical. The patient had no prior history of unusual bleeding, but more testing revealed that potentially malignant stomach tumor. So there is a history given. There is a malignant stomach carcinoma and there is bilateral adnexal masses. So stomach cancer and bilateral adnexal masses, it is most likely to be adenoma, Krukenberg tumor, Brenner's tumor or struma ovarii. If there are bilateral masses, this is likely to be a Krukenberg tumor. So the primary sites, because Krukenberg tumor is a metastatic ovarian tumor. Metastatic ovarian tumor, like you see secondaries in the liver, there has to be primary somewhere in the gallbladder, in the genital tract, anywhere. Okay. Similarly, here the primary sites of tumor can be a stomach cancer, breast cancer or colon cancer. So in this case, stomach cancer is already written. So it is likely to be a Krukenberg tumor. Next, an adolescent girl was brought by her mother to the clinic with complaints of oligomenorrhea and hirsutism. So there's a history of young girl being brought by her mother with a history of oligomenorrhea. That means a menstrual disturbance with hirsutism. So before you read the question completely, young girl, menstrual disturbance, hirsutism, the most probable diagnosis that strikes your mind is polycystic ovarian disease. Ultrasound finding reveals multiple follicles in the left ovary, 8 to 10 mm in size, and left ovarian volume is 18 cc. That means the ovarian volume is more than 10 cc. Plus, there is history of menstrual disturbance plus hirsutism, and it is a young girl. So these findings are clearly directing towards the Rotterdam criteria, and Rotterdam criteria we use for polycystic ovarian disease. Let us see, it is not likely to be endometriosis because endometriosis, number one, it can present in young patient, I am not saying, but endometriosis, why there will be hirsutism and why there will be ovarian volume like 18 cc. So these findings are not matching. Androgen secreting ovarian tumor. Androgen secreting ovarian tumor, there will be features of virilization, and usually it occurs in around 40 or 50-year-old female. It is not with theca lutein cyst, because for the theca lutein cyst there has to be a history of a molar pregnancy or an infertility patient where we have given the human menopausal gonadotropin injections, triggering that we are giving a HCG injection to trigger the ovulation, which is again not matching with this history and findings. So it is polycystic ovarian syndrome. So Rotterdam criteria says there is hyperandrogenism, lab or clinical finding. There is menstrual disturbance like oligomenorrhea or secondary amenorrhea, and ultrasound showing polycystic ovaries. The follicles are arranged in the periphery. Okay, so that is what is a Rotterdam criteria, and this is what is a necklace pattern of ovaries. Next, a 25-year-old female arrived complaining of greenish fluid coming out of the vagina, and there is a strawberry vagina seen. Now, which of the following describes the course of the treatment? So, what is your diagnosis? Strawberry cervix or strawberry vagina and a greenish vaginal discharge is consistent with trichomoniasis, which is caused by Trichomonas vaginalis, which is a flagellated protozoa. So drug of choice for trichomoniasis is not doxycycline, not amoxicillin, not fluconazole. It is metronidazole, and we are supposed to treat the partner as well. Now, greenish color vaginal discharge, itching present, and strawberry vagina. This is trichomoniasis, and the drug of choice is metronidazole. Thick curdy white cottage cheesy discharge, vaginal discharge, itching present, that is candidiasis. Dirty vaginal discharge, fishy smell and no itching, that is bacterial vaginosis. The drug of choice for candida is fluconazole oral and a clotrimazole vaginal pessary. For bacterial vaginosis, again drug of choice is metronidazole, but since it is not STD, so there is no need to treat the partner. Next, the following are associated with tubercular salpingitis with the exception of, which is a wrong statement. Tubes are enlarged, ruffling, and there is a presence of grayish tubercles. This is true. Ampullary part of the tube appears dilated with fimbria and open and pouting. This is again true. Microscopically, granulomas and chronic inflammatory infiltrate hyperplasia may be mistaken for carcinoma. That's again true. Fimbria are commonly involved. That is a false statement. Fimbria are rarely involved. Okay. So the findings of the tuberculosis can be a beaded appearance of the fallopian tube, or it is a tobacco pouch appearance, or it is lead pipe appearance or cobblestone appearance. These are the varieties of genital tuberculosis. So let us see in the HSG images. There are some HSG images which I have added, because if such questions are being asked, you should be able to answer. So there is a lead pipe appearance of fallopian tube. There is hydrosalpinx bilateral. So there is tubo-ovarian masses, and there is fimbrial end usually is free, but there are tubo-ovarian masses. There is beaded appearance of the fallopian tube, as you can see in this image. Then there can be tobacco pouch appearance, you can see, and cobblestone appearance. This is all genital tuberculosis, which is a very important cause of infertility. Now, in severe cases, there are bilateral tubular masses where there is a tobacco pouch appearance, and fimbria are usually spared. Next, 3 months after challenging prolonged obstructed labor. So there is a history of obstructed labor. A woman presents in the OPD and now complains of dysuria and frequent urine leaks. What fits into the diagnosis? There is a history of obstructed labor, dysuria and frequent urine leaks. That means there is incontinence of urine. Obstructed labor leading to incontinence of urine. According to me, it is vesicovaginal fistula, because obstructed labor, in that case, the presenting part applies pressure downwards and it is not able to deliver. So it tries to apply pressure anteriorly. Anterior to the uterus is bladder. So there is pressure necrosis of the bladder and sloughing of the bladder mucosa. So after 7 days or 10 days, after a week or 10 days, the female complains of continuous dribbling of urine from vagina. So this is involuntary passage of urine. So this is most likely, according to me, will be vesicovaginal fistula. Now, we can go for a methylene blue dye test, and many times the question is being asked. So there is an uppermost swab, middlemost swab and a lowermost swab. If the uppermost swab is as it is when we are infiltrating the methylene blue dye into the bladder, and we have kept 3 swabs in the vagina. If the middle swab is stained blue, this is vesicovaginal fistula. If the lowermost swab is stained blue, this is urethrovaginal fistula, which may be a case of criminal abortion. And if the uppermost swab is wet and smell of urine, that means it is ureterovaginal fistula. That means it is ureterovaginal fistula. Now, what is the best investigation for vesicovaginal fistula? So the answer is cystoscopy, because we can see the site size and number of the fistula. Next, a 25-year infertile male underwent semen analysis and the sperm concentration is 15 million per ml, pH is 7.5, volume is 2 ml, no agglutination, morphology is 60% and 60% are motile. So this is normospermia. This is a normal finding. Now, what is the WHO cutoff limit for semen analysis? The amount is 1.5 ml. Cutoff values I am telling. Count is less than 15 million per ml and motility is 40%, less than 40%, and morphology is less than 4%. Progressive motility is 32%. So that is the WHO cutoff findings for the semen analysis. Most important fertility indicator in semen analysis when you are working up an infertility couples is the morphology of the sperms should be normal, and next is the motility, and third one is the count. Next, identify the test shown in this given image, and you can see the electrodes being applied onto the abdomen of the pregnant lady. This is non-stress test. From the image, you can have an idea. This is not amniocentesis, this is not Doppler. So this is a non-stress test where a belt is tied to the mother's abdomen and it is attached to a NST machine, and there's a graph paper running. You can take the recording of the fetal heart rate, and mother is instructed to press the button on the belt whenever she feels a kick movement. So we are assessing the relationship of fetal heart rate to fetal movement, and normal fetal heart rate is 110 to 160 beats per minute. So what parameters we see in the NST? We can see the baseline fetal heart rate, beat to beat variability, presence of acceleration, and there is no deceleration. So this is a reactive NST. You can see this is the fetal movements and this is the fetal heart rate. You can see the basal level is nearly about 130. There is beat to beat variability, and you can see the acceleration in response to the fetal movement. So this is a reactive NST. NST can be done at weekly intervals or bi-weekly intervals depending upon the situation. So it is usually done in cases of pregnancy-induced hypertension, preeclampsia, in IUGR, chronic hypertension, diabetic patients, etc. Now this is non-reactive NST. You can see a straight line. Now next question. A 26-year-old female worked up for primary infertility on HSG, hysterosalpingography. There are bilateral cornual block. What is your next step in management? So here in this case, the cornua are blocked. Are you going to plan a tuboplasty, hydrotubation, IVF? I am not going to plan any of these. I am going to plan a hysteroscopy and laparoscopic guided surgery, because the most common cause for a bilateral cornual spasm is a physiological spasm. So I am going to do a hysteroscopy and hysteroscopic guided cannulation, tubal cannulation. Okay, and with this tubal cannulation, I can achieve the cornual dilatation, and I can put in a laparoscope and check the tubal patency by doing a methylene blue dye, injecting the methylene blue dye from below and seeing that there is a blue liquid from the fimbrial end. So tubal patency can be checked. So I can opt for a hysteroscopy and laparoscopic guided surgery. And if there is hysteroscopically I am not able to cannulate the fallopian tubes, the next step would be the IVF. Next, all of the following statements given below are not correct about the umbilical cord. Which of the following is a true statement? Umbilical vein carries deoxygenated blood from placenta to fetus. We have always studied that the umbilical vein carries oxygenated blood from placenta to fetus. So this was a wrong statement. Umbilical cord has a Wharton's jelly. This is a true statement. Umbilical artery carries oxygenated blood. This is again false. Umbilical artery carries deoxygenated blood from fetus to placenta. Umbilical cord has two veins and one artery. Wrong. Umbilical cord has two arteries and one vein. What happens to the right umbilical vein? It disappears in the 4th month of pregnancy, and left umbilical vein persists as ligamentum teres, and the umbilical artery persists as medial umbilical ligament. All these are important questions. Please revise. Next. A woman had vaginal hysterectomy to treat her cervical cancer. Why these questions are being given lengthy? Because we want to prepare you for a lengthy clinical questions as well. If you get the exam in the single liner form or more image based question, it's going to be a beneficial for you. It's going to be a bonus for you. But if you get a lengthy clinical questions, as it's going to be a next pattern, so then you should be prepared for that. That is what an idea of giving you this CBoT practice tests. So women had vaginal hysterectomy to treat her cervical cancer, and she complained of urinary incontinence after urethral catheter was removed after surgery. Upon examination, she showed signs of continuous incontinence and normal voiding. That means there is involuntary passage plus voluntary passage of urine. Both are present. And her urethra was injected with methylene blue dye into the bladder, and oral phenenzopyridine dye was put. When her pads was examined, after some time there is a yellowish staining of the top cotton pad, but neither of the middle and the bottom were yellow stains. So uppermost was stained wet and yellow because that is a color of this dye. So this is most likely to be uretrovaginal fistula which has developed, because in the cancer cervix we are removing the lymph nodes, and when you're removing the lymph nodes, and suppose you're removing the pelvic lymph nodes or para-aortic lymph nodes for sampling, most likely that you can cause injury. But there is also a chance when you are applying clamps while doing the hysterectomy, you are applying clamps. Here is the ureter which is posterolateral to the uterine vessels. If you are not very careful, you can cause damage or injury to the ureter, which must has happened in this case. Or there may be a cervical cancer which has been eroding the ureter, something or the other cause for this. Or there can be post surgery, there might be given a radiotherapy, and like some complication must have occurred. So it is more likely to be uretrovaginal fistula with the history. Voluntary plus involuntary passage of urine after a surgery for cancer cervix. So it is most likely to be a uretrovaginal fistula. Next, a G2P1L1 lady underwent cesarean section in previous pregnancy. Okay. So the previous pregnancy, the cesarean section was done for a fetal distress. Now this time she has underwent a vaginal birth, that is VBAC, vaginal birth after a cesarean section, but placenta could not be removed completely. The cord snapped on traction and the placenta did not deliver. So patient is bleeding profusely. So that means it was a scarred uterus and they have tried to deliver the placenta. But placenta could not be delivered and the patient has started bleeding profusely. Placenta is still attached. So what is the likely cause? So that means there's a history that she has been a case of previous LSCS and vaginal birth after cesarean has been conducted. But placenta could not be delivered and she started bleeding profusely. Most likely after a cesarean section, if you are not able to deliver the placenta, it is likely to be an adherent placenta. And what is that condition called as adherent placenta? This is called as placenta accreta. It is not uterine inversion, it is not succenturital lobe, it is not placenta previa. So it is placenta accreta. Because had it been any type of a placenta previa, they would have done a planned cesarean section, but they have attempted which would have come. The placenta previa diagnosis must have come in the ultrasound finding, which they must have got it done during the pregnancy itself. So that means it was not a placenta previa. And when the placenta did not come out, it is not succenturital lobe. And when the uterus is still intact inside in its anatomical position, so it is not acute inversion of uterus. So this is adherent placenta, which is placenta accreta. So in this case, most likely since it is a multiparous lady, they might have to proceed with the hysterectomy. So this is placenta accreta, where like Nitterbuck's membrane, that is a membrane that separates or that prevents the invasion of the trophoblast into the myometrium. So in this case, placenta accreta or adherent placenta, the Nitterbuck's membrane is absent. So the chorionic villi invade the superficial layers of myometrium, that is placenta accreta, full thickness of myometrium, that is increta, and up to the serosa layer, that is percreta. For these situations, I recommend it is hysterectomy. Now, during the dilator test, a woman who has had 2 abortions before, and easily you are able to pass number 8 Hager's dilator. Hager's dilator number 8 easily, and there is history of previous 2 abortions. So this is most likely to be a case of incompetent cervical os, and another way to diagnose this, it can be done by HSG or it can be done by ultrasound. In ultrasound, you get a finding of shortening of cervical length to less than 2.5 centimeters. Okay. HSG, what do you find? You find funneling of cervix. So management in this case will be a, like for incompetent os, we go for a cervical encerclage operation. So this is Hager's dilator. Next question. A 24-year-old lady with 8 weeks history of amenorrhea, positive urine pregnancy test. So she is 8 weeks amenorrhea. 8 weeks amenorrhea. Urine pregnancy test is positive, but vaginal examination, and a vaginal examination reveals an empty uterus and adnexal mass. Transvaginal finding also shows that uterus is normal size and there is adnexal mass. Okay, which of the following test will sum up with her next evaluation further? Is it immediate emergency laparotomy? No way. Laparoscopy? No way. Estimation of serum beta HCG or 3 doses of methotrexate? We never give 3 doses. First of all, we always give first dose. But first of all, I would like to confirm that it is a case of ectopic pregnancy. So the best investigation has been done, transvaginal scan, which shows there is an empty uterus and there is an adnexal mass. But they have not written about the gestation sac and the cardiac activity in this adnexal mass. So next, I would like to confirm my diagnosis. I would like to go for an estimation of serum beta HCG to arrive at a diagnosis. Okay. Next, identify the given instrument. So this is not Carmen's cannula, this is not MVA syringe, that is manual vacuum aspiration, that is done for MTP. It is not Spexman's cannula, this is a Rubin cannula. Rubin cannula was used for the air insufflation test for tubal patency. Air insufflation test for tubal patency in cases of infertility. But this is very obsolete test, because in this test Rubin's cannula was inserted. Rubin's cannula was inserted and air was injected into the uterus. Air will enter into the uterus and strike the diaphragm, and lady is supposed to tell the doctor that she is feeling a shoulder tip pain. So this is most obsolete test now, and we use the Leash-Wilkinson cannula. So this is Carmen's cannula. Carmen's cannula is usually used for suction evacuation method, or we can use it for doing the endometrial sampling as well. This is MVA syringe, that is again used for MTP. Next question. A pregnant lady with 10 weeks period of gestation presents with spotting. On ultrasound, there is a gestation sac seen but no fetal pole. What is the likely diagnosis? At 10 weeks, you are just seeing a gestation sac but no fetal pole. So that means it is most likely to be a case of missed abortion. Inevitable, incomplete and threatened, I have already discussed in the first question itself. Next. An investigation was conducted on a woman who had an abdominal lump. She had smooth surface ovarian tumors on both sides during the surgery, and there's a signet ring mucin secreting cells. What type of likely diagnosis? So since it is a mucinous secreting signet ring cell we see in the Krukenberg's tumor, which is bilateral, and the surface of the ovary is smooth and the capsule is intact. So this is signet ring cells, Krukenberg's tumor. Next, a 29-year-old woman who is nulliparous with infertility, uterus reveals that it is retroverted, fixed. Uterus is retroverted, fixed, and there is tenderness in the pouch of Douglas. Tenderness in pouch of Douglas, that means it is endometriotic spots in the pouch of Douglas. Uterus is retroverted and fixed, that means there are adhesions. Retroverted fixed, that is adhesions. Tenderness in the pouch of Douglas, so it goes with endometriosis, because endometriosis is occurring in a young female reproductive age group, and if this patient is married, so might be there is infertility. That is written, so it is a married patient, nulliparous, infertility with a normal sized fixed retroverted uterus with tenderness in pouch of Douglas, that is endometriosis. What is the gold standard investigation in endometriosis? Answer is laparoscopy. What is the most common site for endometriosis? Answer is ovary, that is chocolate cyst of ovary. And if there is moderate to severe endometriosis on laparoscopy, what is your management? In moderate to severe endometriosis, in moderate to severe endometriosis, when there is so much of adhesions that you cannot treat by surgery, so in that case you can go for IVF. Endometriosis means presence of endometrial tissue outside the uterine cavity. Most common site is the ovary. Other sites can be pouch of Douglas, rectovaginal septum, appendix, sigmoid colon, etc. Now, 25-year-old lady arrives with a history of bleeding after sexual activity. Examining the specimen revealed the following appearance. What is the diagnosis? Looking at this with a polypoidal mass coming out from the cervical os, it is unlikely to be a CA cervix, because number one, it is occurring in very young female and bleeding occurs, that is a history of postcoital bleeding. So postcoital bleeding can occur in cancer cervix and cervical polyp as well as. Okay, so looking at the history, which is little bit incomplete appears to me, 25-year, very unlikely that it is a presentation of a cancer cervix in such a young patient. So it is most likely appears to me a cervical polyp. Nabothian follicles do not present like this as the image is given, and cervical fibroid is on the cervix, lip of the cervix. Okay, it's not like this. Next question, which of the following requirements must be met in order for a registered medical practitioner to be authorized to perform MTP under the updated MTP Act regulations? House training for 12 months, wrong. House job for 6 months. 6 months house job in OBS Gynae can entitle for an MTP. Should have assisted 16 MTPs in authorized centers? No. It is 25 MTPs in government approved authorized centers. Certified for 6 months in laparoscopic surgery? No. It has to be some qualification in OBS and Gynae. So having a degree or diploma in OBS Gynae. So the correct answer is A, that is 3. So in the new MTP Amendment Act 2020 or 2021, you should know the upper limit for MTP is 24 weeks. MTP is legal when done up to 24 weeks and till 20 weeks. Opinion of one doctor is enough. From 20 to 24 weeks, opinion of 2 doctors needed. In the special cases like rape, unmarried girls, etc., if the pregnancy has gone beyond 24 weeks, can MTP done? Yes, that case goes to a medical board and they decide. Medical board consists of a gynecologist, pediatrician, radiologist, and a gazetted officer appointed by government of the state or the union territory. And if they say, okay, you can go ahead with MTP, then MTP can be done beyond 24 weeks as well as. Then who can perform MTP? A registered medical practitioner who has assisted 25 MTPs in a government approved authorized center, a doctor who has done 6 months of house job in OBS and Gynae, a doctor who has done MD, MS, DGO or DNB in OBS and Gynae can perform MTPs. So also pay attention to the indications of MTP and complications of MTP as well. Next, a lady who is parous observes a swelling at the vulva that becomes less as she lies down. Okay, so swelling gets reduced when she lies down, and she also has a trouble starting with micturition process. So that means there is history of difficulty in urination, and there is a swelling which reduces on lying down and appears on standing. So these findings are not in favor of cervical fibroid, not for uterine prolapse, not congenital elongation of cervix. This is cystocele, that is bladder prolapsing in the vagina. And what is the surgery for cystocele is anterior colporrhaphy. Anterior colporrhaphy, remember this. And number 2, what is most common type of genital prolapse? Most common type of genital prolapse is cystocele. Most common type of genital prolapse is cystocele. Next, a woman presented to our OPD with primary infertility. On examination, it is found to have nulliparous prolapse of the uterus. Nulliparous prolapse means only the cervix is, or the cervix is prolapsing. It is not cystocele, rectocele. What would be the most appropriate management in this case? Ring pessary? No, ring pessary is done when the patient is having genital prolapse and she is pregnant, or she is in the purpurium, or she is elderly unfit for surgery. Fothergill operation is done in a multiparous lady, but she is young, having genital prolapse with cystocele, rectocele. Then Fothergill operation is tried. Cervical amputation alone is not done. So here for the nulliparous prolapse, we go for a sling operation. Sling operations are done for a nulliparous prolapse where there is only cervical descent, there is no cystocele, rectocele, and the type of surgeries can be the Purandra's sling surgery, Khanna sling operation, etc. or Shirodkar sling operation, and there are modifications also available. Next, in cases of gestational diabetes, which of the following problems is not seen? Preeclampsia is associated with diabetes. This is true. Abortion is associated with diabetes. Yes, because in gestational or pre-gestational diabetes and the lady is pregnant. So pre-gestational diabetes, if the blood sugars are not being controlled, then there is likely to get abortions, because the diabetes leads to congenital malformation, and congenitally malformed fetuses are likely to get aborted. And there is always a risk of infection, but oligohydramnios is not associated with diabetes, rather polyhydramnios is seen. So with this, I end up my session. Hope you have seen or you have checked the answers with my discussion, and hope this session is useful to you. So this was a very final revision. Be prepared for the clinical questions, image-based questions, previous year questions, and the single liners. So all the best and Thank you.